Mr. Johnson, we're going to start with assessment of your vision. And visual acuity is determined by either a wall-mounted Snellen chart or very commonly a pocket Snellen chart, as I have here. Mr. Johnson, would you take your right palm and place it over your right eye? And I'm going to hold this about 14 inches in front of Mr. Johnson's left eye. And could you read the smallest line possible?
Okay, 2, 4, 8, 3, 7, 6, 1.
Okay, you can bring the arm down, and if you put your palm of your left hand over your left eye, and would you now read the smallest line possible?
6, 9, 0, 2, 8, 3.
Okay, you can bring the arm down. It's important to test visual acuity either with a formal Snellen chart or anything that has any print on it. Very commonly what you might do is ask a person to read the smallest line possible on anything that you might have by your patient, and then use something else to test the vision in the other eye. What we're going to do now is assessment of the external eye structures. And Mr. Johnson, if you just look at my nose, and we will now bring down the lower lids, inspecting the tarsus, the lids, and the conjunctiva. We'll elevate the upper lids, looking at the lacrimal gland area in this area. And we're going to check also whether or not there is injection or dilatation of the blood vessels in the conjunctiva over the sclerae, noticing the size of the pupils and the shape of the pupils as well. We're now going to check visual fields by confrontation field testing. For this procedure, the patient is asked to remove his or her glasses, and the examiner must remove his or her glasses as well. For this procedure, you want to stand approximately 2 feet in front of the patient, and you'll ask the patient to close his or her right eye as you close your left eye. So, Mr. Johnson, could you close your right eye for me? And I'd like you to look at my nose. And I'm going to close my left eye and look at your nose also. The hands are placed slightly closer to me and in the nasal and temporal fields of the patient's left eye. Mr. Johnson, tell me how many fingers you see now.
3.
Okay. And how many fingers do you see now?
4.
Okay. Try again. How many fingers do you see now?
3.
Okay. What we're doing is assessing the nasal and temporal fields in the lower fields and in the superior fields. Please close your left eye. I'm going to close my right eye. Look at my nose. I'm looking at your nose. And Mr. Johnson, how many fingers do you see now?
3.
Okay. And how many fingers do you see now?
3.
Good. You can open your eye. Please make sure that when you do this procedure that the hands are closer to you, allowing the person to have the advantage of a larger field, and also that the palms are facing you as you hold up your fingers. We're now going to determine eye alignment and the pupillary responses to light. So David, what I'd like you to do is look in the distance, and I'm going to shine this pen light straight ahead, and I'm going to see where the light falls on individual corneas. We're looking first at the right and the left, and you'll notice that the light falls right directly in the center of the pupil, indicating that the eyes are straight. We're now going to continue on by using our pen light to check pupillary responses to light. And David, just continue to look in the distance as I shine this light from the side and shining it first on the left eye, looking for the direct and then consensual pupillary reflex, and then from the other side, the direct on the right and the consensual pupillary reflex on the left. We're now going to continue to test extraocular muscle function by means of evaluation of the cardinal positions of gaze. Because the rotational action of the obliques and vertical recti muscles cannot be easily assessed, the eye must be moved into 6 diagnostic cardinal positions of gaze that best isolate the vertical actions of these muscles in order to test their innervations. The oblique muscles are tested in adduction, that's where the eyes turn medial toward the nose, to maximize their vertical action. In contrast, the vertical recti muscles are tested in abduction, abduction. That's with the eyes turned laterally. In these positions, the superior rectus muscle acts now as a pure elevator, and the inferior rectus acts as a pure depressor. We're now going to test extraocular muscles. In order to do that, the examiner stands about 2 feet in front of the patient and stabilizes the patient's jaw. The other hand is placed with one finger in front of your nose, and the patient is asked to follow your finger as you go through the 6 cardinal positions of gaze. David, I'd like you to follow my finger. Okay, don't move your head, and follow it out here. You bring it out to about 15 or 18 inches from midline, all the way up here, and now we're testing the inferior oblique of David's right eye, the superior rectus of his left eye. As I bring the finger down, I notice the position of his eyes, being careful not to poke the eyes. We're now testing the superior oblique of his right eye and the inferior rectus of his left eye. Bring him back to mid-position. We're going to now switch hands. David, just follow my finger as we go all the way to the right, testing the medial and lateral recti, coming all the way up here, now testing the superior rectus of the right eye and the inferior oblique of the left eye. As we come inferiorly, we'll elevate the lids again to test the inferior rectus of the right eye and the superior oblique of the left eye. We're coming back to mid-position. David, I'd like you to watch my finger very carefully as I bring it in close, and we're now testing convergence of the eye, and we will then conclude this assessment in this position. One of the most important parts of the physical examination is the ophthalmoscopic examination, providing us with a wealth of information about the patient's health. This is the only non-invasive means of directly viewing vasculature in its native state. I'm going to demonstrate the use of the ophthalmoscope by using 3 different types of equipment. The first is the standard direct ophthalmoscope. A direct ophthalmoscope is an instrument which has a series of lenses which takes into account your refractive error as well as the refractive error of the patient. It's a light source which allows visualization of the cornea, the lens, the vitreous, and the retina. In order to use this instrument, you want to use the instrument held in your right hand using your right eye to examine the patient's right eye. In order to do this, you should remove your glasses and have the patient remove his or her glasses as well. If the person is wearing contact lenses, or if you're wearing contact lenses, they may certainly be left on. The light should be placed on, as I'm demonstrating here, and the patient is asked to look in the distance. You should stand approximately 15 to 20 degrees off midline and elevate the patient's upper lid as the ophthalmoscope is placed against your right eye to examine the patient's right eye. The first thing that you'll notice is the red reflex. If a red reflex is not seen, one has to be concerned that there may be some opacity, such as a cataract, in the lens. As you move closer to the patient, you will turn the lenses to focus deeper as one gets into the eye, past the lens, through the vitreous, and then into the retina. You must always be at eye level with the patient. First visualize superior nasal, inferior temporal, and superior temporal. And Mr. Johnson, please look at the light. And at that last second, the patient's macula has looked directly at the light, and one is looking then at the fovea of the macula. We repeat the same procedure on the left eye using your left eye and holding the equipment in your left hand. And again, I'm about 15 to 20 degrees off of midline, and keep looking in the distance. And as one gets closer to the patient, the diopter wheel focuses, First, as we go through the cornea, the lens, the vitreous, and now the retina. The optic disc is well visualized, as is the vasculature. Looking superior nasal, inferior temporal, superior temporal. And Mr. Johnson, look at the light, please. Thank you. This is the wall-mounted ophthalmoscope, and its operation is quite identical to the handheld unit. The only difference is that instead of the control on the handheld unit here, one has the on switch here. And the control of the intensity of the light is by this knob right here. In the newer wall-mounted unit, the brightness control is in fact in the handle. When one places it back into the holder, the instrument is turned off. The third instrument for direct ophthalmoscopy is the panoptic ophthalmoscope by Welsh Allyn. This provides a panoramic view of the fundus and provides a 5 times larger in diameter view than the standard direct ophthalmoscope. You can easily find the optic disc and the surrounding vessels, and it's easy to enter small non-dilated pupils. Whereas the standard direct ophthalmoscope provides only a 5-degree field of view, the panoptic provides a 25-degree field of view. This is actually 26% more magnification than the standard direct ophthalmoscope. The other advantage to the panoptic is that there is a greater working distance between the patient and the examiner, and I'd like to demonstrate it right now. The panoptic ophthalmoscope works with any of the standard 3.5 volt handles. This is the head, and this is the eye cup, and I will demonstrate its use in just a moment. First, one wants to use the continuous focusing wheel to focus on a distant subject, to get that subject in sharp focus. And then the equipment is used basically the same as your standard direct ophthalmoscope. A major difference is the eye cup. The eye cup, which aids in the stability of the unit, is applied directly to the patient's brow and is depressed about half of the length of the eye cup to visualize the red reflex. You should be able to see the optic disc, the physiologic cup in the disc, the arteries, and the veins. The cup is the portion of the disc that is central, lighter in color, and penetrated by the retinal vessels. The normal ratio of the cup to disc diameter varies from 0.1 to 0.5. The examiner should check the cup to disc ratio in both eyes for symmetry. The retinal vessels are evaluated as they arborize over the retina. The central retinal artery gives rise to 4 main branches that supply the superior and inferior aspects of the temporal and nasal quadrants of the optic fundus. And again, one will examine all of the quadrants as well as the macula in the standard fashion. A major advantage of this is that many individuals are one-eye dominant and therefore may have trouble using their left eye to examine the left eye of the patient. With the panoptic, if you just turn this way, Mr. Johnson, and look straight in the distance, I can actually visualize Mr. Johnson's left retina by using my right eye, as I'm demonstrating now. In addition, of course, I could use the instrument in my left hand and examine the left retina as well. How are you feeling? Fine. Okay, we're now going to proceed to the examination of the ear. The first part of the examination of the ears is inspection of the external ear. One looks at the external ear and notices the helix, the antihelix, the tragus, the antitragus, and the external auditory canal. We want to palpate also. Mr. Johnson, does this hurt at all? Okay. Tenderness by pulling on the lobule or the antitragus will provide pain if the person is having an acute otitis externa. We're now going to evaluate auditory acuity, and there are basically 2 ways of doing that. One by whispering something in the patient's ear, and the second is a tuning fork test. Mr. Johnson, would you take your hand and place it in your external canal and tell me what I've said?
Train. Train.
Okay, and if you now occlude the other canal? Hospital.
Hospital.
Okay. We're now going to proceed with the evaluation of auditory acuity by a tuning fork test. Typically, one uses a 512 hertz tuning fork. This happens to be a 128, which is certainly acceptable, but a 512 is generally the one which is used. There are two tuning fork tests, the Weber and the Rinne test. I'm going to demonstrate the Rinne test first. Strike the tuning fork by placing it into oscillation by striking the heel of your hand and then placing the vibrating tuning fork on the mastoid process of the patient. Mr. Johnson, do you hear or feel anything?
Yes.
Okay, tell me when you stop hearing it or feeling it.
It stops.
Okay, what about now?
I can hear it.
Okay, so air conduction is greater than bone conduction, and that's normal. AC greater than BC. The examination is conducted in the other ear as well. And do you hear or feel anything?
Mm-hmm.
Tell me when you stop hearing it.
Okay.
Okay, and what about now?
Yeah, I can hear it.
Okay, so air conduction is greater than bone conduction bilaterally. The second test is the Weber test, and one strikes the tuning fork and places it midline on the patient's forehead, and the patient is asked, do you hear or feel anything?
Yes.
Okay, tell me what you hear or feel.
Vibration.
Okay, where do you feel it?
Both sides of my head.
Does it feel equal, or is it in one place louder than another?
No, it feels equal.
We call that no lateralization, and that is the normal Weber test. I'm now going to demonstrate the otoscopic examination. The otoscopic head is put onto the handle, and the speculum, the largest diameter speculum, is used. In order to visualize the patient's tympanic membrane and external auditory canal in the right ear, the examiner places his left hand on the mastoid process and pulls up, out, and back, thereby straightening the external canal. The instrument may either be held this way to enter the canal or this way. Either way is acceptable. The most important part, though, is pulling up, out, and back to straighten the canal. In doing such, you will straighten the canal, place the speculum into the external auditory canal, and visualize the external canal and the tympanic membrane. You'll notice the malleus, the umbo, the light reflex pointing anteriorly, and perhaps other ossicles in the middle ear. To examine the left ear, the examiner uses his or her right hand to pull on the tragus and earlobe up, out, and back, and the otoscope can be entered into the external canal either as was demonstrated on the other ear or held in this manner, and the speculum is inserted as I'm demonstrating now. We're next going to inspect the nose and the nasal skeleton as well as the sinuses. Any tenderness here?
No.
Mr. Johnson?
Mm-mm.
Any tenderness here?
No.
Tenderness here?
No.
And what about here? Any tenderness here?
No.
This is evaluation of the frontal, maxillary, and ethmoid sinuses. Evaluation of the nose is done by having the person extend the neck and using a light source and elevating the tip of the nose, looking in the nares to see the position of the septum and if there's any discharge or separation of the septum.